if you have any questions, please feel free to ask me any questions. My name is Leslie, and my last name is Prescott. I've been an occupational therapist for going over like 17 years. I'm originally from New York, and I relocated to Connecticut, and I specialize in low vision rehabilitation. So that's my specialty area. As for my education, I'll start out from the beginning. I have a bachelor's in science degree in psychology from Niagara University, and I have a bachelor's in science from Mercy College, as well as a master's degree in occupational therapy from Mercy College in Dobbs Ferry, New York. I have a graduate certificate in low vision rehabilitation from University of Alabama in Birmingham, where I studied under Dr. Mary Warren, who is the creator of UAB Low Vision Rehabilitation Program, as well as the creator of the brain injury visual assessment for battery for adults by VAVA, which she trained everyone personally. I also trained under Dr. Beth Bostow, who is the current director of UAB's low vision rehabilitation program, and she's also my mentor. I went on to receive an occupational therapy doctorate from UAB with concentration in low vision rehabilitation. My capstone focused on the effectiveness of low vision rehabilitation for increased function with older adults with age-related macular degeneration. And from my capstone, I really have a lot of great raw data in terms of, how many sessions you would normally do with patients. And I'm still working on because it's a retrospective study, and I'm really trying to publish it. So in the long run, that's what I'm still working on. I would like to inform you that Dr. Beth Bastow and others, about 40 of the certified low vision therapists, the CLVTs and the SCLVTs, we collaborated sometime last year, and it's been a year, but we are currently creating an association. So it's called Vision Rehabilitation Occupational Therapy Association, but it's a working group. And the reason why I'm informing you about this is because I am the leader. Dr. Bastow made me the leader of the research committee. We have several committee: advocacy, research, and we have education. And we have been making some waves with AOTA. Like if you go on AOTA, we already changed the fact sheet of what is low vision. And my research committee, we just finalized our survey, which is a needs assessment that all OTs are going to receive. So if you see a survey from Vision Rehabilitation Occupational Therapy Association Research Working Group, please fill it out, because we're trying to set standards with ACOT with all low vision programs in the states. And a copy of the survey, if you have a CLVT, which is Certified Low Vision Therapy certification, like Michelle, you're going to get a survey, because Dr. Steve Whitaker, he's on my research committee, and he's going to issue that to the listservs of the CLVT. So look for it. And Dr. Julie Nastasi is also on the research committee, and we're going to meet as a group next week. Well, more to come, because I really want to talk a little bit more about that, but it means a lot for us, because it's going to be a great resource for all of us, all OTs, so we're doing everything consistently. So I'm just going to go over the role of occupational therapy in low vision rehabilitation. It's just, let's see. Why isn't it? Sorry, I think I got a little. Okay, sorry. Okay, I want everybody to meet Jerry. Jerry is my mother-in-law. She's 82 years old, and she's the mere reason why I decided to focus on low vision rehabilitation. She was diagnosed with glaucoma like maybe 15 years ago, so she lived with it. She was really independent. She had her own home. When we relocated to Connecticut, she relocated from the Bronx, bought her own little house, and I've been working with her as her vision has deteriorated, modifying her house, just doing OT stuff with her. And that really made me want to focus and go into low vision rehabilitation. Well, what is low vision rehabilitation? In terms of age-related eye disease, it is a chronic medical condition affecting 1 in 6 adults over the age of 45. 2/3 of people with low vision are over 65 years of age. It's a visual impairment that you really have to understand. It cannot be corrected with glasses or any type of surgery. And it's also severe enough to interfere with activities of daily living. It's a visual acuity of 20/70 or worse in the better seeing eye. But the unique part about it, it will allow some usable vision. But my takeaway is this: unmanaged diabetic retinopathy and glaucoma can cause blindness. So it's really imperative to be in charge and top of your eye care. All right, low vision is not blind. Complete blindness is the inability to see anything. You can't even see light. Routine medical and self-management for diabetic eye disease and glaucoma, that's really important, because without the routine management, complete blindness can occur in those two conditions. That will leave you with unusable vision. So I'm going to put things in perspective for you. So when you go to your eye doctor, you see the Snellen Big E eye chart, and it's in the backlit boxes all the way in the distance. So just to give you a perspective of that, the Big E is 2200, okay? And a lot of patients who come in to see me, if they're considered legally blind, they would fall worse than 2200, meaning that when they went to the eye doctor, their better seeing eye, they could not see the 2200 at all. So the doctor will probably say, okay, can you see my fingers? And then if the patient can count the fingers, the doctor will put down, count fingers, 2 fingers, a foot away from the nose. And then if they couldn't count the fingers, wave hand. And then the doctor will say hand wave only if the patient can see the hand wave. And then if not, resort to the light and see if the patient has light perception only. If not, then the eye is no light perception. So just to give you a little perspective, mild vision loss is considered 20/30 to 20/60. And now this classification is from the World Health Organization. So this is a worldwide classification. And then we considered a patient low vision when at the better eye is 20/70 to 21/60. And then when it gets worse, 2200, like only seeing the Big E, that's when the patient is classified as legally blind. Now, the NIH, the National Eye Institute, and I trained about 24 OTs already in the state of Connecticut, my 6-hour intense course. And I played videos, a lot of videos from the National Eye Institute, and the low vision doctors, the specialists there, and it's also my take on it too as an OT, is that although low vision is considered 20/70, they are looking at when the eye disease impacts on function. That's when they would need low vision. That's when they'll need vision rehabilitation. And as occupational therapists, we see patients who are not low vision, patients that expose stroke with field loss. They might not be low vision, but they have field cuts that impacts on their occupation, their function, and that's where they'll need occupational therapy. And they're kind of in other low vision departments are looking at that. So patients with reading acuities of 20/70 or less will most likely require magnification, enlarged print, or assistive technology for reading. Now, if you get a patient with a mild vision loss like 20/30 to 20/60, this is what they'll need. They can read well with reading glasses. If not with reading glasses, with adequate lighting. So not too much intervention in terms of optics are really required if they have like a mild vision loss. But I find, especially with age-related eye disease, lighting is key. And I'll go into that a little bit more. Okay, one thing that you have to know about age-related eye disease, and this really set home with Jerry. Most older adults with age-related eye disease had normal vision their entire life until the onset of the vision loss at an older age. Some older adults just might view vision as, oh, it's just a normal aging process. I'm getting old, I can't see, I need readers. They might not follow up with regular eye care. Oh, it's, I'll go to my PCP. That's more important. I don't really need to see the eye doctor. I'm getting old. They might not be receptive to low vision. And that happens a lot, because when I receive patients from eye doctors who are new and they really never heard about the Lions Low Vision Center, they might tell the patient, oh, she might have eyeglasses or something for you to make you see better. And they'll come in expecting that. And I would have to explain what I do. They might feel that, again, the right eyeglasses or surgery will restore their vision back to normal. So there are 3 eye diseases that account for low vision in older adults. The first one I'm going to talk about is macular degeneration. So these diseases are age-related and an increase in incidence as the person gets older. There's absolutely right now no cure, resulting in permanent visual impairment. Vision loss is one of the leading causes of disability in the United States. And that's what I found when I did my capstone in research. Now, this is a picture, an illustration of, how a street sign will look with someone with normal vision. And this is a little example of how a person with macular degeneration might see it. They really don't see blackness, but what they see, and they describe as something that's hazy, blurry. It's kind of distorted. It comes and goes, and it pretty much mesh in together right in the center. So that's a lot of my patients' perception of vision with macular degeneration. So this is really giving you a real idea of what the retina looks like. So there are 2 forms of macular degeneration. There's the wet exudative AMD and dry non-exudative AMD. Both wet and dry result in vision loss. A person with age-related macular degeneration will have functional deficit, like light sensitivity would be a functional deficit they'll come in with. They'll come in with increased visibility with light. So lighting is something, because I'll explain a little bit about some of the scotomas that they have might have some photoreceptors. They call them threshold. So with the photoreceptor cell there, with the right lighting, they could see through that. If it's dense there's no photoreceptor cells, they cannot see through it. So I find that they will do better with light. But then they have like slow light dark adaptation. Like if they're going out of the movie theater, it's really dark, and they go in the bright sun, they're going to be blind for a little bit. That's even an age-related thing, adapted to light and dark. They're going to have reduced color vision. They're going to mistake navy and black a lot. They're going to have a lot of different other color changes, because a lot of our cone cells are right in our central field. They're going to have difficulty with contrast. If it's things that are similar in contrast, it's hard for them to differentiate between different contrasts. They'll have problems with curve cuts, especially if it's not highly highlighted. I'm sorry. Okay. And then they're going to have the big key is they're going to have difficulty with reading and writing. Again, the central field is where we see the clearest. So they're going to have difficulty with reading and writing, and difficulty seeing features, facial features in detail. And as you can see with the wet macular degeneration, they have very leaky blood vessels, and then it starts to hemorrhage a little, and there's medical intervention for that. They get injections of medication to kind of not cauterize, but just stop the leaky vessels, because you don't want to have macular edema. That's going to cause more damage. And the dry macular degeneration, there's no injections, there's no type of medical intervention, but vitamins that they research support. It slows the process of the eye disease. Now we're going into diabetic eye disease. So basically, this is a illustration, a picture. It affects all over the eye. And this basically, it's uncontrolled blood sugar levels. It causes macular edema sometimes, and then you get the leaky vessels. I'm going to go into the picture of that. And so you have like deficits all throughout the retina, all throughout the eye here, and it's really hard for them to function. So these are some of the things that we have to look at when we get a patient with diabetic eye disease. Again, healthy eyes, healthy blood vessels, their blood vessels right there gets a little bit leaky and hemorrhage. And what's really dangerous about diabetic eye disease, if it's not managed correctly, you might get macular edema. And with that, what can happen is that your retina can detach. And when your retina detached, that's emergency surgery, or you'll lose your vision altogether. So that's the prevalence of this eye disease that has to be managed. They have to see their eye care professional, their retinal specialist on a more consistent basis. I have my patients seeing them every 3 months, some even more. So health management and education is very important. So it's really important for OTs to make sure that they have care providers in place. You have to work on strategies and modification to control their blood glucose level. And we do have some low vision aids that we technically can train patient with diabetic eye disease so they can manage their insulin. We have like an insulin type of smart device that makes sure that they're getting the right dose, and a lot of other things we can work with. But most importantly, we want to make sure the patient's seeing an endocrinologist if they're not. We want to know if they're seeing a certified diabetic educator to provide training on meal planning, medication, and glucose management. A nutritionist referral, if appropriate, just to make sure that they're on the right meal plan, diabetic diet. And, a podiatrist to cut their nails, especially if they're on blood thinner or they have any neuropathy, that they, basically will do skin checks and make sure that everything is looking well with their skin, because you don't want them to lose a limb. And now we're looking at glaucoma. So basically with glaucoma, for the most part, not all, because sometimes some people with glaucoma might have central field loss as well. But for the most part, there's normal vision, but it doesn't hurt. It's permanent vision loss, and it's very subtle. And it is the damage of the optic nerve based on the intraocular pressure is elevated. And so with glaucoma, like with my mother-in-law, Jerry, she's homebound, but we have to take her to see her glaucoma specialist, who's an ophthalmologist, every 3 months, because he has to monitor her pressure and make sure that she's on the right medication and that is not progressing for her to totally lose her vision. So it's loss of peripheral field for the most part. And you don't really notice it until it really turns into like something that results in almost tunnel vision, or it results in you're noticing that you're scanning a lot more to different directions because you're not seeing your whole peripheral field, and you're walking into things. So this is pretty much what it looks like. So it's buildup of aqueous humous fluid here, like an open or closed angle glaucoma. We usually have a mechanism where the fluid would basically drain, but with glaucoma, the ability for that to happen doesn't happen. And then the pressure will develop, and then the optic nerve, which is right here, it will start damaging. And sometimes it gets inflamed. And sometimes we have an optic disc that's right here. You might see cupping and damage going on there. So patient education is, you want to educate the patient of the etiology of the eye disease. That's really important. Importance in medication management, because with glaucoma, the patient most definitely are taking some sort of eye drop in the morning, eye drop at night, or eye drop in the morning. And that eye drops are supposed to keep that pressure down. They have to attend regular eye exam and report any changes in vision. Glaucoma is painless. It doesn't hurt. It often it's not detected until the patient really feels the vision loss, or the doctor detects it when he does the pressure during the eye exam. If the patient, I'm sorry, I'm just jumping ahead. If the patient does not attend routine eye exam, total blindness can happen with the glaucoma. So I like to really talk about the prevalence of eye diseases in the United States. Now, I received this from the NIH, and starting in 2010, we had, for age-related macular degeneration, close to 2 million people over the age of 60 with age-related macular degeneration. It's projected by 2030, we're going to have 3,664,000 people with it. And it's going to project to get even higher by 2050. Over 5.5 million people will have macular degeneration. And as you see, it gets higher as the patient gets older. So the need of occupational therapy and low vision rehabilitation is really high because of the prevalence of the eye disease. Same thing with diabetic retinopathy. In 2010, there were over 7,600,000 people. 2030 is projected to have over 11,350,000 people with the diabetic eye disease. And if you can see, the age is a lot younger, okay? And then it's projected by 2050 to have over 14,559,000 people with this eye disease. So the prevalence is really equating that we need more of this. Glaucoma, the same thing. Again, it starts younger at 40. At 2010, close to 3 million people with glaucomas, projecting by 2030 to be over 5 million. And by 2050, over close to 9 million people with glaucoma that's going to need services. So what is occupational therapy? You know, what is our role in low vision rehabilitation? What is occupational therapy in general? Occupational therapy is the only profession that helps people across the lifespan to do the things that they want and need to do through therapeutic use of daily activity. Occupational therapy practitioners, we enable people of all ages to live the life to the fullest by helping them promote their health. And in our case, we are to prevent or help the patient live better with injury, illness, or disability, because we can't restore the vision, but we can prevent further disability, and we can help them compensate, come up with compensatory strategies and low vision aids so that we can maximize their independence and safety so that they can really live their life to the fullest. So occupational therapy low vision referral form. Now, this is a standard Lions low vision form that is on the Lions website. I don't know if it's updated, but Tom gave me the most updated version of it. So we receive, the eye doctor receives this form, and we receive on the form the primary diagnosis of the patient and secondary diagnosis if appropriate. I get patients sometimes with macular degeneration and glaucoma, and I think that's a real good information for me to know so I know what treatment approach to really look at. And they want to authorize occupational therapy to distribute magnifiers. So we don't give that because we don't prescribe. If it's not prescribed by opticians who is licensed in the state, or ophthalmologist and optometrist who's licensed in the state of Connecticut to prescribe optics. We want to know their best corrective acuity. We want to know the type of scotomas, if it's relevant to the patient. We want to know, the MD, ophthalmologist or optometrist signature on there. And they're pretty good with filling out this form. Sometimes they include their case note with that to give us more information. Now, what is the role of occupational therapy in low vision rehabilitation? Specifically, as you can see me there with Jerry, occupational therapy practitioners have a holistic perspective in which the focus is on adapting the environment and or tasks to fit the person, and the person is always an important part of the therapy team. So occupational therapy is extremely evidence-based. Low vision is evidence-based. It's a practice rooted deeply in research. It is something that we use standardized functional visual assessment like this. This is the BIVAVA. This is going to give us a standardized guide for intervention. It's going to tell us what the functional deficits are. And unlike when the patient goes to the doctor and there is 2,200, this BIVAVA form, this is an intermediate acuity, this size right here is 21,000. So it's giving us functional numbers as to what's the largest print size the patient could possibly see. So it's allowing us to provide appropriate intervention. On the average from my capstone, and this is only with age-related macular degeneration, and just by knowing how I schedule my patients, I see the patients for the initial evaluation where I'm just doing a functional assessment. That's all I do. I don't do any treatment. I don't issue any low vision aids. I do the BIVAVA on my patient, and I do an outcome measure. And I never count the evaluation as a visit. So once I finish the evaluation, I am scheduling 4 treatment sessions with the patient. The 4th treatment session would be the plan of care update to see if we achieve the goals, or we're going to come up with new goals and work on new strategies and continue with services. So I just based on my research and based on my practice, I, on average, see patients in 5 sessions. Okay, we train the patient to use his or her remaining vision as efficiently as possible to participate in activities. For an example, teaching a patient with central loss, like with macular degeneration, eccentric training, viewing training, like you see me doing here with Jerry. I'm teaching her to compensate by using another part of her retina that is not affected by the eye disease to see more clearly when performing activities of daily living. Now, if a person only have a central scotoma, like macular degeneration, I have patients like maybe if I teach them, if they look on different areas like up, right, left, I have a patient that has to look above and then he's looking eccentrically to be able to see a target better. That would be an example of eccentric viewing. Okay, and also common functional deficit, personal care, grooming, feeding, locating food, meal preparation. As you can see, I had to modify the environment so Jerry can feed herself independently. White bananas on black plate, dark food on a white plate. She sees red pretty well. So you want to modify the task and the environment to make the patient independent and doing things that they don't require help in so that they can eat. And we also look at adaptive equipment such as non-optical devices for older adults to complete their daily activities. For an example, the Lions have writing templates to increase contrast. So you see this senior citizen writing a note, and she's using a writing template. They love this. This template will help them be able to address an envelope, write a check, sign their signature, write a note in and also their grocery list. And that's the biggest part that they come and they want to be able to do. And then that low-tech, low-vision aid is an intervention. And that's like gold for them because it's bringing them back to perform those type of tasks. And we also use non-optical devices for older adult like task lamp to increase visibility for reading and writing. We have this device as one of the low-vision aids that we typically use to increase their independence when they're doing a task. We also have large contrasting keyboards for their computer. My low vision aides who are on the computer, that's game changing for them. They can see all their keys. They can engage in their Facebook or do their work on their computer with a contrasting keyboard. And another non-optical contrasting aid would be our low vision telephone. A lot of our older adults have old-fashioned telephones. Let me go back. And they would like to basically not use cell phones. So this is a really high contrasting phone that they love. And it's very simple to use. And they can store up to 10 numbers in there. And then also glare is a problem with everyone with low vision. So we have glare protection fit over the glasses that fits over the top and the sides. All my patients love that glare protection, and the eye doctor loves the fact that we have that as a device because it's something that can protect their patients' eyes when they basically are in the environment. And we're also experts with optical devices. And assistive technology is my favorite, okay, because there's so many free apps, free things out there. So we can help with prescribed opticals, such as the handheld magnifiers to help them spot read expiration date on medicines, or they want to see the nutrition facts or something like that. They can use that because magnifiers are not really meant for continuous reading. It's meant for spot reading. And this is actually my computer. I have a touch screen, so that's why it says mouse pointer touch. As you can see, my big mouse pointer. You can go in the accessibility and make the mouse pointer really big and nice contrast, like it's black on white. And then when it goes on the black, it turns white. And then here's my cell phone. You go to accessibility. As you can see, all of my writing on there are all extra large. And I train my patients to use Siri or Alexa if they have an Android to do everything for them. And they love that, like make phone calls, check their email, open up apps. So there's a lot of hand-free things that you can use their own technology for. And then we look at assistive technology for older adults, such as portable video magnifiers for reading documents. So they portable reading magnifiers. This is reading a menu, and some of them reads distance, like a stop sign. And then we have CCTVs that you can read documents. You can read continuous reading, like you can read books, magazines. You could put, I have patients that put tools under there so they could see tools if they like to put things together. So there's a lot of different things that we can do with patients to maximize their ability to continue to be independent. Now, we also do environmental modification. Now, this is Jerry's house before she moved in with us. And these are some of the things I did with her in her house so that she can be independent with using her stove. So I'm going to go into that with you real quickly. So this is Jerry's house before she lost her vision and she developed dementia. That's why she had to move in with us. So we provide therapeutic intervention, task or environmental modification, adaptive equipment, and low vision aids. Now, Jerry, when she first became low vision, I think Rachel, one of the Lions, she evaluated Jerry when she was first diagnosed with low vision, when it got really bad. And she trained Jerry, and Jerry received some nice low vision aids, which we currently have. So she has this big high contrasting clock that she could still read. Her low vision telephone, the black version you can see there. Jerry prefers this type of contrast because glare bothers her. And she also had the iPhone that I modified and the calendar. And those are some of the aids that we all have in our low vision inventory. And this is what I did for Jerry's oven so she can use her stove and microwave. I used touch dots, and for her, she was able to see black for off, yellow for low, red for high. So that's the system she used in order to turn her stove off, and it's tactile, so she can touch it and she can see the colors. And these were her favorite settings on the microwave. She was able to use the microwave with the touch dots. And that's another low vision adaptation we have at the Lions. And these are some of the other modifications I made for her home environment. I had a motion light for her clothes. I also color coordinated it for her. And I portioned her food in microwavable safe dishes so she didn't have to prepare her food. It was easy for her to make. So those are some of the strategies that we do. And we also look at common functional deficits, depth perception. We look at low contrasting environment. Now you can see these stairs blend in together. Jerry would not even see any of that. So adding light will give you a little bit more depth, and lighting is key, especially with low vision. So specifically, and in my training, I had a workshop where I did a lighting assessment with my participants, as well as I do that all the time. Even though I'm outpatient, I make recommendation on what type of light bulbs based on the lumens they could see with the lighting assessment. So lighting assessment is both subjective and objective. So occupational therapy practitioners are trained expert in environmental modification. So evaluations include standardized assessment that evaluates how visual limits activity. So I have a light meter. And what I would do, I would use different lighting, like I have this lamp, and I would use different light bulbs, and I would measure the lumens that the patient has in the light that's on the task, and I would have a light behind the patient, so with the light bulbs in there. And I measured the effectiveness of each bulbs, and what I would do, I would compare their initial reading acuity score to the reading acuity score they perform with the light. And that's how I would make a recommendation. So we also have motion lights as part of our inventory. And this will make us understand what type of intervention, like maybe we would recommend them putting motion lights on their stairs to increase their visibility on stairs. For Jerry, this was her house. So I for her outside lighting too, to make sure she was safe. She could see red really well, so made sure her door was red so she could see her red door. And we made sure her lighting for a backyard, everything was flattened. She had lighting back there, especially at night. Now Jerry she developed, after the pandemic, she developed dementia. So we had to take our finished basement, and we converted it to a permitted accessible permitted accessible granny apartment. So it's completely flat. This is the basement, so our laundry room is here, our stairs is closed off, and she has no access to the stairs. She has a walkout, everything, no threshold, everything is flat. So I was like, it was my dream as an occupational therapist to work closely with the architect design to design an apartment that was visually, cognitively, and motorically accessible. So with that said, my focus as an OT, I wanted to make sure she had an Alexa at home so we could drop in and see her and she can communicate through the Alexa. Camera, especially for dementia, is important. We had cameras throughout, no threshold, a walkout basement, and there's absolutely nothing she could trip and fall over. So specifically, this is her bathroom. So as you can see, they love me because they said, Leslie, do you know how hard it is to mix black grout with white? I said, listen, everything has to be high contrast. So I made sure everything contrasted in terms of the tile on the floor was black, the toilet's white, a black seat so she could see. Now, one of the hazards as OTs we notice is that the sink is always next to the toilet and the sink gets a little wet and it's a fall risk. So we have this pull down handrail that's always down that she always grabs onto for safety. The lights, we have the electrician, as soon as she turns it on, all the lights come on. She doesn't have to press any button. This is a linear drain, so she doesn't really need a curtain. All the water drains going in, nothing goes in the toilet side. Handheld shower, she has a built-in bench that contrasts with the shower, black and it's matte. Grab bars in the shower, grab bars next to the bench, is next to the bench and in the shower so she could transfer and set. And basically everything, vessel sink, she can grab onto that. Everything was made with vision and cognition in mind. So one of the things that's really important with all low vision patient, and I know that during my training, I had a nice long video that kind of tied in everything I'm talking about. And they really talked about this towards the end of the video, which is really prevalent, is that low vision patients are aging in place. You know, they want to remain in their own home and a lot of them have minimal assistance outside. So depression is in psychosocial effect, especially with the pandemic, social isolation and not being able to go out as much. Depression is very prevalent. It's common in older adults with low vision, 2 to 5 times more likely to develop depression. And it's greater than other common age-related conditions. So these are the signs we look for. Patients that don't want to socialize, they don't want to go to shopping, they don't want to engage in meaningful activities. Like they say, I just want to sit down. I don't even want to watch TV. I don't even want to listen to the radio. And this is all going to lead to social isolation. So we watch out for things like that and we provide intervention as needed. So in conclusion, occupational therapy practitioners, we have a holistic perspective in which the focus is on adapting the environment and task to fit the person. And the person is an important part of the team. Occupational therapy is evidence-based practice. It's deeply rooted in science. We use standardized functional visual assessment to guide our intervention. We have to know where the deficits are in order to make recommendations. I have to know what acuity the patient has so that I can make recommendations on the size print for medical information from the doctor's office or any type of educational information I'm providing to the patient, or recommendation of the size font print that the family would make for when they want to make big phone numbers down there. To give you an example, when I assessed Jerry, her eye doctor said she was only able to count fingers. Her functional acuity, she couldn't see the big E at 2200, but in her better eyes, it was 2400, to give you an idea. So the font size that she can see at 2400 was 66 point. So I wouldn't have known that if I didn't do a functional assessment. So basically that gives us strategies so that we can implement strategies so that we can maximize independent. And we're also experts on low vision aids and assistive technology, lighting, and contrast to increase visibility for IADLs. So the next thing I am going to talk about, I'm going to talk about my student. I am honored to have an entry-level occupational therapy doctorate student from Quinnipiac University. Her name is Sarah Hannon, and she's on this Zoom meeting. And I'm going to really give her an opportunity to take over and talk about her capstone, because her capstone is going to really change the scope of what we do in terms of making sure that the community and eye doctors know who we are and where we are. So Sarah, if you're there, if you want to take over and let everybody know what's going on.
Hi, everyone. Thank you for listening to me today. So I am Leslie's student. I started working with her, I'd say like the last week in March, and I've been working on this capstone project for well over a year. But basically I am creating with Michelle Tarantino, who's also on this call, and her group of MOT students. I'm creating a website that will have all the resources that those in Connecticut with low vision or any visual impairment have access to, because a lot of them are unaware of what resources they have access to, and they're unaware that a lot of these resources are free and offered to those in the state of Connecticut. So right now I'm surveying Leslie's patients as they come in and just asking them how their experience was and how they were referred to Leslie's services or any kind of low vision services, how they found out, and finding out what their diagnosis is, how confident they feel in their knowledge of their diagnosis. And then I'm going to send out this website to them and then send up a follow-up survey to see how they felt that helped them and what kind of services and resources they felt they had available to them. So I've been going to, I went to the Connecticut Library for Accessible Books, which is now what they call it, and met with Chris Radio and various OTs. So that just kind of figuring out what the resources have and who they're available to. So yeah, it's been great. I mean, I've been learning about low vision training as well and how to do that with the patients. Yeah, it's all been great. So I'm just very, very excited to have the opportunity to build this website and give it to those in Connecticut that, you know, have a visual impairment.
And the eye doctors.
Yes, and the eye doctors. That's what the MOT students with Michelle, they are surveying the eye doctors in the state of Connecticut as well, to kind of figure out more about that referral process. So then the website will benefit the doctors and the patients. So then the doctors can know exactly what low vision OTs do, which is very, very important.
That's wonderful. So, any questions? That's the end of the course. I have resources here, and I will stop sharing. Okay, that's it in a nutshell.
Okay, are there any questions at all? Hey, Carolyn.
Hi there. Leslie, I want to thank you. Listening to the passion behind your words makes us realize how this truly is your calling, and thank you for sharing your expertise with us. I was wondering, for the Bivaba, do you tend to administer it on all low vision patients or just those with background of dementia, brain injury, etc.?
Okay, to give you a sense of the Bivaba, Dr. Warren normed it on people with traumatic brain injury and hemianopsia. So, but the Bivaba actually was normed on the neural population, but can be used on every patient with any type of eye disease. So if you look at the Bivaba, I only use for the age-related one and how it was trained by Dr. Warren. I use all the acuity aspects of the Bivaba, and I also use the contrast sensitivity aspect of the Bivaba. The Bivaba kit has a lot of subtests in it that's appropriate for stroke, and also people with glaucoma, because they're going to have abbreviated scanning strategies that you get to see exactly what it looks like and what type of intervention are you going to give them. Now, I want to mention one thing to you, Carolyn, and everybody else. Dr. Warren reached out to me recently, and if you go to her website called Visibility, where you would purchase the Bivaba, she is offering all OTs free HEP PDFs, which is wonderful. All you have to do is put in your email address so she can contact you. So she's giving you resources I have so the HEPs of what you would do when you're training is centric viewing, reading and writing, central scotoma. It's all free now. You can download it. And she also, I think Tom, when I went to the last training with Tom, I think her husband told Tom, but she eventually told all of us that she has videos that can show you how to administer some parts of it. You can't download the videos, but you can reference it.
That's excellent.
And she also has an online neuro training for training people with any type of neural disorder. And that's only like $100, I think, and that's online, and she offers that as well. So she's providing a lot of free resources. That's key. So yeah.
Tell us the name of the website one more time.
It's called Visibility.
Okay.
Okay. And if you just Google Mary Warren, it'll just come up. And it's her personal website. That's where she has her training. That's where she sells the Bivava. You cannot get it on Google or Amazon. She sells it. That's her own thing. So yeah, and it's normed on a 5th grade level. You can even use it on children if they can read on a 5th grade level.
Wonderful. Yeah, I'm curious if show of hands, there's 15 other people in this room. What other centers own the Bivava and are administering it?
All the centers.
Yeah.
All the
centers.
They
all, let me say it this way. They all own the Bivava. It's whether they're administering it, as the second part of your question. But they all have them.
So what I do like about the Bivava is that it's very easy to administer. And as you can see me, I like to show pictures. That's really something that I'm doing. I'm evaluating Jerry in her apartment. It's easy to take around with you. And once you learn how to use it, it's like really easy to do. And it gives you a standardization. I really kid you not. When I receive referrals from the eye doctors, my score and their scores are the same. And they're using the fancy smancy Humphrey and all this other type of equipment, and I'm just using the card. But it gives us the same sort of outcomes, which I think is measurable. If another OT were to do it on the same patient, the results would be the same. And plus, it helps with intervention. It tells me, like, especially the contrast sensitivity one, it tells you the functional deficits the patient will have if they can only see a certain contrast. You're going to know that they need more lighting. You're going to know they're going to have problems with ambulation. So it gives you a lot of tools to what you need to look at when you're providing intervention. So, yeah.
Any other questions?
Oh, yeah. And Dr. Warren is also providing a link to UAB where you can download. It's called the Revised Self-Report Assessment of Functional Visual Performance. And I use that assessment in my capstone, but that's fantastic because it's measurable. And it's a self-report of a lot of different visually dependent activities, from grooming to leisure activity. And the patient on a Likert scale get to rate if they're independent or they cannot perform. And at the beginning, when I first see my patients, I conduct that. And I always measure the scores from the beginning to progress to discharge, or beginning and discharge, to see if my intervention was measurable. And it also kind of really lets me focus. Like, they might come in, I can't read, I can't write, but there's a lot of things in terms of meal preparation they can't do. So I address that because it's something I'm having difficulty with that. I'll take them to our rehab kitchen and I'll work on some strategies to mark up the oven and microwave in there, and then they'll go home and they'll know how to do it. So it really provides you a good resource for intervention as well. And you can use it for home base because you can put it on your iPhone, your iPad, and it's really easy to do, and that's free.
Great. Does anyone have questions for Leslie regarding issuing and assessing for magnification aids? Nothing? Okay. You're all feeling pretty comfortable. All right. And as far as it sounds like obviously, I love, Leslie, how you kind of, no matter what, you schedule 4 to 5 visits on average, then you do a plan of care, which
I
makes
do.
sense. Yeah. Do
I-
you find it challenging for those over? I find only because I don't know why in New Britain, we tend to get a lot of people over the age of 95 and they're, it's hard for them for transportation to get as much, but as many visits. But I think you do such a great job really working on buy-in. And it sounds like your patients very much attend your visits.
Oh,
There's
yeah.
no shows, etc. So that's
I do have
wonderful.
no, I do, well, not so much as because either because their ride couldn't bring them, but
Mhm.
we're working on strategies. Before the pandemic, Griffin actually paid for lift services for my patients, but they're not doing that anymore. So a lot of my patients, I'm working with PT2 because we use like, there's a car service that bills through their insurance called Vial, I think it is. And a lot of my patients, they're linking up with their their senior centers and they're getting rides that way. A lot of my patients get rides through their family. So they find a way to get to me. And if not, I really pretty much look into the community and see what type of ride program is available to get them to see me.
That's wonderful.
Yeah.
I've wondered, I mean, there is something you've probably heard called Uber Health, where
Yes.
I was always curious from a financial standpoint. It would be wonderful to find an organization that possibly would donate to put money into Uber Health in order for these clients that may have difficulty getting to and from their therapy visits. Obviously, I wouldn't put that on the Lions because they've got enough going
No,
on, but
they're doing enough.
just curious if anyone else has heard that any organizations that support Uber Health and donate towards that. I was just wondering if anybody else had that
Mm.
Carolyn,
experience.
you might be able to reach out to the New Britain Lions also and say, hey, could you pick up a patient? This person can't make it. And sometimes I can't say they always would, but there could be that possibility.
Okay,
And
yeah,
most of the people that have outpatient services, if you have a Lions Club in your town, they're a good facility to talk to, or a good organization, as a club. They sometimes will do that and to help. So,
good point. Good point. And we've been so lucky. We've had Alan for many years who did that.
yeah,
Yeah.
he was terrific.
Wonderful, man. Thank you. Any more
Leslie, I have a
questions?
question. Yes, I have a question. This is Cindy. I'm in the Hartford.
Hi, Cindy.
Hi. When you're administering the BIVABA for the evaluation, and you're asking them to either read the numbers chart or the Warren text card for reading, we haven't yet taught them how to locate their PRL.
Right,
So-
I haven't either.
So if we're using that, the result of that, to determine what their acuity level is and possibly what magnification they need. And then at a future session, we're teaching them to find their PRL. Sometimes once they use that, they can read at a much
Mhm.
smaller print level.
Mhm.
So when do you determine what level of magnification they need if they can see better once they have been taught to use the PRL?
Okay, that's an excellent question, Cindy. Okay, that's why the way the way Dr. Warren, I should call her, the way she framed the BIVABA is that rule of thumb, you're giving credit for the if they at least say 2 numbers on the intermediate acuity, because with the macular degeneration, they might see some of the numbers, but it's covering the others. But their critical size acuity would be the 2 that they can see, or 1, but so they get credit for the 2. So you're getting their functional acuity. In terms of the reading, we have to go until they make a mistake. Now, I do the PRL, I don't have enough time to do it at the initial assessment. I do it most of the time during the second visit, where I basically teach them eccentric viewing. I have them looking at the clock face. I map out where they see distortion, and then I train them how to use their PRL, and I give them homework, and then I go over the HEP with them. Now, in terms of magnification, you know, I really don't jump into that right away, honestly, because what I do with my patient, I'm really evaluating the whole patient. And what I'm finding for me is that I really barely deal with magnifiers as much, because lots of times my patients, they have iPhones, they have laptops, they have iPads, they have we call it Amazon Fires. They have things that can offset as one, you know, and there are a lot of apps on iPads and iPhones that can do all that for you, reading for you. So it's case by case, but in the event that I'm working with a patient that needs a magnifier, I find it that I train them how to use their PRL first. And then after I train them how to use their PRL first, I work on them reading the BIVAVA again, and then seeing if their acuity has changed. And then once they're acute, they usually do a little bit better. And then I look at the diopters that's recommended next to the acuity line. And then I go get that magnifier. I train them how, if the patient needs a handheld or if it's dexterity issues, I'll go get a stand magnifier. I give that patient a magnifier and they do 20/20. Like if not, they do a lot better. And that's how I measure if the magnifier is effective. I never like go over optics before I know that they know where their clear spots are. So that's to answer that in a long, a long breath. That's usually what I would do. Yeah.
Super helpful. Thank you.
Yeah, that's what I would do, because you're doing two things. Your eccentric viewing is telling you, okay, my patient found their clear spot. Can they see that line better? They might see the second line under that one better. Oh, wow. Okay, so that's working. And then you can segue into, okay, well, let's look at that magnifier. Let's see how you do with the magnifier now. And then that will give you an idea if that's the appropriate one and if the patient really would perform better. And then you know you have the right one.
Thank you.
Oh, great questions.
Let me ask a question. How many folks, are actually using your BIVAVA kits? I can't see everybody, so, but what I can see, a lot are. Okay.
Tom, I won today, actually.
And I think people have their hands up,
Okay,
like a hand.
okay, I see the hands, yeah, thank
Yeah.
you, thank you. So a lot of you guys are using them, so, oh, that's good, okay, I was kind of concerned that maybe, it's a piece of equipment that we or your organization purchased and it wasn't really being used a lot, so.
And my takeaway is that you can use it on neuro patients too, right? Not just for low vision, use it on your neuro patients, because right? Because there's a lot of subtests in there that's appropriate to look at scanning strategies, and also HEPs that you can give them. Go to Mary Warren's website, download her HEP. And also, if you want to review certain aspects of the BIVAVA, she has videos. You can always look at her videos so that you can say, okay, how do you do that again? And that's something that you can do. That's a good resource I think she's providing. Oh, good. So I think Ronald put down
Roland, yep.
visibility. I see it. Thank
Yep.
you, Ronald. Thank you. Thank you. Yeah. So, my goal, I guess my goal is my passion doing this, but my goal is I'm working on, because in my committee, I'm the leader of the research committee, but the people in my committee are well researched in the field of low vision. You have Dr. Julie Nastasi, Steve Whitaker, who is on the board of the CLVTs. I'm working on becoming an approved continuing education AOTA provider, and it's daunting, it's hard, but I'm working on doing that, so that I can really provide continuing education for more OTs across the states. In the interim, I am working, I really appreciate all the 24 OTs feedback on my course evaluation, knowing what you would like to know more about, specifically assistive technology, specifically more intervention. So that's something I'm looking more into as well, and I'll keep you posted, Tom.
Hi, Leslie. It's Vito.
Oh, hi, Vito. How are you?
Good. How's it going?
It's going great.
So I have a question. When you mentioned some of our neuro patients, I do treat a lot of neuro patients at Main Street Rehab. And how do you tie in some of that population with stroke or ALS, TBI, and low vision? How do you tie those two together?
Okay. That's an excellent question. So like with the stroke and the TBI, like with the TIA, you might have inattention, you might have field cuts, and lots of, like I evaluated a patient with status post stroke today. And, just watching him with the BAVAVA, like missing the numbers on the left, missing the first numbers here, just functionally watching him taking the BAVAVA just gave me a lot of information in terms of the way he can see things. So it was normed on that population. And so if you look at the subtests in there, like circle search, you have a circle that's a target, and you have to, one is random, one is simple, and you look at their scanning strategy. Are they having abbreviated scanning strategy because of their stroke? Are they having inattention, not paying attention to the left or right side? And then that's something that you can educate the patient on. I realize that you're ignoring this part. What can I do to anchor you over here? So there's a lot of subtests in there that's appropriate for that population. And if you look through the kit, you'll see a lot of different subtests in there, and you could do HEPs. And there's another functional thing you can do, which I do a lot with my stroke patients, is that I do a scan course. And what a scan course is, you might have like post-its, or you might have cones, and you might put it in different, like on the walls, or in different variations of the environment. And you tell the patient, I want you to find the cones, I want you to find the post-its on the wall, and you get them to scan the environment, and you get to see where they're missing something and where they're finding. And you can really train them how to really use their usable vision more efficiently by scanning the environment or paying attention to their environment. It matters like what type of functional deficit they have, status post to brain injury. So yeah, that's really appropriate for that. And there's so many strategies you can use with that.
Yeah, awesome. And with the Lions Low Vision Club, is it appropriate, or have you recommended certain equipment for that population with who have like hemianopsia or contrast sensitivity or things of that sort?
Absolutely. I'm finding that, not so much magnifiers, because, for the most part, they have 20/20 vision, but they just have a field cut. I'm finding that contrast and lighting are certain issues with people that have those type of sort of field cuts and things. Contrast is really key. Stroke, traumatic brain injury, glare is going to be a nightmare for them. Those glare shades are game changers for a lot of people, status post-traumatic brain injury. It's really going to hurt their eyes to be in an environment where there's a lot of light directly on them. So I go a lot through glare shades with them, a lot of lighting with them. Based on the contrast sensitivity test, I get to assess what type of contrast they need, increased contrast to do certain activities. I might use a lot of the templates because it adds the contrast. I use a lot of different strategies to actually provide cues so they can orient to areas that they're not seeing. So there's a lot of different strategies I do use, and some of the Lions devices that I do use to kind of complement what I would normally do as an OT if I didn't have the Lions.
Great. Thank you, Leslie.
You're welcome.
If no one has any more questions, I did record this meeting. I hope that's okay with Leslie, and I'll share the recording on the follow-up email. I do have one question for a person that is calling in just with the phone number 860-734-6004.